Good evening. This is Meldita, and I'm back. So, our topic is Ecg interpretation, but there are things to know before we do our Ecg interpretation. Number one, location of the pacemaker or focus. And here, I have a drawing of the heart, and we just spoke about location of the pacemaker or the focus. SA node, that is our dominant pacemaker. Next in line is the AV node, that is the escaped or the latent pacemaker. Next in line is the ventricular, somewhere in the His and Purkinje area. And that is another site of the electricity or electrical stimulation. Sometimes we have reentries. Another pacemaker can happen somewhere outside the circuit. We have here either the right atrium or the left atrium. And you see these two circles in here. These are atrial foci. And there is another one that could act as a pacemaker, and that is located inside the AV node, right here, inside. Or it could happen either on the right or on the left ventricle, this one here. Reentries, they could go in circle, on and on. The rate is fast. Next, rhythm. Are we dealing with an ECG that is regular or irregular? When you say regular, it's coming from sinus node. It could be from the AV node, or it could be from the ventricular area. It could be irregular, like atrial fibrillation, and that could happen in the right, coming from the right atria. I told you that is an outside pacemaker. There are also, or could be flutter, and there is also the tachybrady, right down here, or the atrial tachycardia here. Okay, so sometimes our atrial flutter can also be irregular if the ratio is exact, 2:1 AV ratio. But normally it varies, but the AFib is very irregular, so they're both irregular, usually. Next is the rate. You have to consider the rate of your ECG. Is it normal, fast, or slow? Okay, so I'll discuss a little bit of the different rates in here. The rates of the sinus rhythm is 60 to 100. The atrial is 60 to 80. Junctional is 40 to 60. Ventricular is 20 to 40. They all come in beats per minute. The atrial flutter, they're really fast. They could go 180 to 350, but ventricular wise, they only go slower than that. It depends on the block. The atrial rate is here 180 to 350. I'm not talking about ventricular rate here, because the ventricular rate is based on how many blocks, how many blocked P's there. Atrial fibrillation, their ventricular rate is usually 140 to 160, but their atrial rate is 350 to 600. No such thing ventricular rate could be 350 to 600. That person is already dead long time ago. VTAC, the rate is 100 to 200 per minute. Torsad, 150 to 250. So those are the rates that we will consider in doing our ECG interpretation. Next, morphology or configuration. You have to look closer about their morphology or configuration. Example, number one, or letter A is P waves. There are many designs of our P waves in here. Okay, that is normal, right here. Next is a flat. Usually that flat T is usually atrial. And there's also AFib, a piece, and there's a flatter piece. There are not piece. And the inverted P wave here, that could be ischemia, or the peak T wave here could be atrial enlargement, and the biphasic P wave here. So they could be normal, small, chaotic, flutter, notch, or inverted. PR interval. Usually the normal PR interval is 0.12 to 0.20. And sometimes the PR interval is short. Okay, the first one here is a normal PR interval. You see that one. Next one, we have a short PR interval here. You see that mostly in Wolff-Parkinson or Lange-Ganning syndrome. Sometimes you see a long PR interval, first degree block, or they could go second degree, type 1, which is Wenke back. So you have to consider those things. Next is QRS. The QRS could be normal, and usually it's equal to less than 0.10 seconds. They could be narrow, which is expected, but when they got tachycardia, they will say, is it wide or narrow? So wide, are we dealing with bundle branch block in here? So the first one is a normal QRS in here. Next one, we have wide. So is this VTAC or it's just bundle branch block? There are parameters to consider, but the mere fact it's wide. Okay, so usually with bundle branch block, you look at your V1 or V6. And if it is a left bundle, rabbit ears, you see that in V6. Okay. And then here, you could have also right bundle branch here. And that is more prominent in V1. Sometimes you see a QRS that is with spike. Okay. That is a pace QRS. It could be a temporary pacemaker, univentricular, permanent, or it could be an ICD because they have also pacemaker with ICDs. Okay, that's before the QRS there. So that's probably a univentricular pacemaker. Sometimes you see a QRS that has two spikes. These are CRTDs where we have biventricular pacemakers. Right ventricle, left ventricle, each one has its own pacemaker. Next is the monomorphic VTAC, which is wide. Okay, the last one is an agonal rhythm. Either it is a too late resuscitation, the patient is dying with this kind of rhythm, or if they make it, cooling protocol and so forth will be in ICU. Next thing to consider is the ST segment. The ST segment could be isoelectric, elevated, or depressed. The first one here is normal, is isoelectric. The second one here, I put there a red ink there, is ST elevation that is noted in STEMIs, ST elevation MIs. And there are also these ST depressions here. Either, or they could be horizontal, it could be downsloping, it could be upsloping. These are non-STEMIs ECGs. Another one to consider is the T wave. Is your T wave normal? Is it peaked? Or is it with U wave? Okay, that is my normal T wave here. I'm showing you. There's a peak T wave in here. It's either your potassium is high, hyperkalemic, very common for renal patient,